everyone. Yeah, thank you so much for the opportunity. So I am here today to talk about this work that we have in partnership with the University of Liverpool, where we explore sort of current and future patterns of inequalities in diagnosed illness in England by socioeconomic deprivation. So the broad structure of the presentation is going to be giving you a little bit of background and context of the work, some of the methodology, and then going into the findings in terms of the existing patterns as well as the future patterns, and then ending with the implications of the findings. Right, so moving on to the background and context. So obviously, why is this important and what is this adding to what is already out there? I mean, people in this room would know that health inequalities now, there is so much research happening in the area. It is a focus area for the NHS, for the different political parties. We've been hearing about it a lot. I mean, those stats that you see up there about, the life expectancy gap of 8 to 10 years between people living in the most and the least deprived areas, the healthy life expectancy gap of 2 decades. I'm sure most of you will be familiar with these statistics. So what is it that our particular research is adding that is new? So a lot of the commonly reported metrics in health inequalities, like healthy life expectancy or disability-free life expectancy, they use self-reported health measures. So what we are doing is we are trying to complement that evidence by looking at patterns of inequalities in diagnosed illness and looking at it in a lot of granular detail, which is what our data would allow us to do. And I will go into a little bit more detail on the data and things in the coming slides. And also, to our knowledge, we are one of the first studies to project what is going to happen to health inequalities in England in the future. And also, we want to make the point that, this is not, health inequalities does not just exist in a vacuum. It is not just a health problem. It also has implications for the wider economy. And so a lot of my findings will be focusing on the working age population to, again, make the point about the implications for the wider economy. So moving forward, and sorry, there will be maybe a little bit of repetition from Anita's keynote if you attended that yesterday, but just in the interest of people who have just joined today, I will give you a brief introduction into the work. So this is a long-term program of research with the University of Liverpool. So Anita actually presented almost parts 1 and 3 yesterday, where she was looking at the projections of illness, which was Health in 2040, that was produced last year, and then sort of tacking on activity and funding to that to look at what those projections then mean for funding needs for the NHS. And so what I am doing is I am doing a deep dive into those patterns of illness, but by socioeconomic deprivation. And so the report is called Health Inequalities in 2040. It was published in April of this year. In terms of previous iterations of projections that we have done, this version has a lot of improvements. One of it is the fact that we have better data. So we use linked primary care, secondary care, along with mortality records, which allows us a very detailed picture of patients' illness histories. So this is CPRD ORM linked with hospital episode statistics and supplemented with ONS mortality records. What the partnership with the University of Liverpool enables us is to use a state-of-the-art microsimulation model that has been developed by them for over a decade now, validated, very well published. And that allows us, and it gives us a better understanding of the relationship between sort of long-term illness, aging, and multimorbidity. And what it also allows us to do is sort of look at multimorbidity, but then link it to risk factors. So essentially what's happening in the model, and I will go into a bit more high-level detail about the model, is we're looking at trends in common risk factors, looking at based on the causal relationship that we have between different risk factors and long-term conditions, then using that to project what we would anticipate for illness, as well as then multimorbidity into the future, and in this case, health inequalities. And also, Anita briefly touched on this yesterday, we also use a fairly novel measure for multimorbidity called the Cambridge Multimorbidity Score. And so this is a weighted score, and I'll go into a bit more detail in the next page, but essentially we're using the score, which uses 20 common conditions as an aggregate score for multimorbidity. Right, so moving on to the methodology. So like I mentioned, one of the novel aspects of this work is how we measure multimorbidity. So we use something called the Cambridge Multimorbidity Score, developed by researchers at the University of Cambridge. So this takes 20 sort of common, high cost conditions, which together account for 2/3 of the burden of illness in England. And what it does is it assigns a weight to each of these 20 conditions based on how they impact primary care appointments, emergency admissions, and risk of death. So you have a sort of combined weight based on these 3 parameters for each of the 20 conditions. And so, for instance, if a person had multiple conditions, you would just be able to add up the scores and you would get an aggregate multimorbidity score. And so this allows for things like time series analysis or different subgroup analysis. And so what you see at the right is basically the 20 conditions in descending order of weights. And also specifically within the research, rather than look at a non-zero CMS or people with any illness, what we do is we focus on major illness, which is this threshold of 1.5. So essentially, and that we use as sort of like our proxy for sort of high cost, high care illness, essentially. So you can see that based on the weights, you would reach that threshold of 1.5. In most situations, you would have to have multiple conditions to reach that threshold. But also, if you had dementia or cancer on their own, that would push you over to the threshold as well. So that's essentially, so a lot of my coming findings are going to be focusing on major illness. Right, so moving forward. Yeah, so this is a very high-level structure of the microstimulation model. It's called the impact NCD model. Liverpool actually have this for different countries. And so this is obviously the impact NCD model for England. And like I said, what this is doing is this is combining individual data on demographics, survey data on risk factors from Health Survey for England, and then the linked patient data, along with epidemiological evidence on the causal relationships between risk factors and long-term illness to then project long-term conditions. And so you can see the sort of like the wide structure. So you have the individual demographic things, so age, sex, ethnicity, region, deprivation. That then affects the likelihood of having a behavioral or a biological risk factor, so things like alcohol, smoking, physical activity, biological being things like systolic blood pressure, cholesterol, BMI. And those together then affect your likelihood of the onset. So incidence is the onset of a given long-term condition, as well as the mortality with a given condition. And then those together then affect the prevalence, so the share of the population with a given condition at a given point in time. And then with our metric of major illness, we can then aggregate that to look at trends in sort of multimorbidity, or in our case, major illness. Right, so what do we find? So when we look at current patterns of, and just to say that this is diagnosed health inequality. So this is the socioeconomic gradient that people might be pretty familiar with in terms of other metrics of health inequality. So just to say that we see a very similar pattern when we look at diagnosed health inequality as well. So this chart is showing you the share of people with major illness by age group and by decile of deprivation. And you can see that inequality sort of very clearly increasing throughout working age. And also in the 20 to 29 category, actually, you can see that even though overall prevalence of major illness is quite low, inequality is already sort of setting in by that age, and it's just continuing to grow throughout working age. And then it sort of levels off in the oldest age group. And that is because people with the poorest health in the most deprived areas have already died by that age. And so then the remaining people, there isn't a lot of difference in their health between those who survived to that age, between people in the most and the least deprived areas. But also in terms of, so the red bits again are just trying to highlight the working ages, so the 20 to 69 years here. So you have 15% of people of working age in the most deprived areas having major illness, which is more than double the rate that you have in the least deprived areas, which is 6%. And so based on the data that we have, this very granular data that also allows us to look at the specific conditions that contribute to these diagnosed health inequalities. And what we find is out of the 20 conditions that we look at, a group of 7 contribute to nearly all of the observed health inequalities that we see between people in the most and the least deprived areas. So this is age standardized prevalence of these 7 conditions by decile of deprivation. And so you can see that these conditions are chronic pain, anxiety and depression, type 2 diabetes, COPD, and cardiovascular conditions like coronary heart disease, stroke, and heart failure. And in terms of relative inequality, you can see that, for instance, that's highest for COPD. So the prevalence of COPD in the most deprived areas is 4 times that of the least deprived areas. And so, again, based on, you might be familiar with the concept of healthy life expectancy. So what we can do is create our metric of healthy life expectancy using diagnosed illness. Obviously, it's very different to healthy life expectancy because they're measuring completely different things. But essentially, we are defining sort of healthy here as being free of major illness. So essentially, this is showing you the difference in major illness-free life expectancy, it is a bit of a mouthful, between women, this is just for women, living in the most and the least deprived areas. So the total length of the bar is life expectancy. And if you look at the red bit, that is the time, the expected time that you can spend without major illness. And you can see that there is a 10-year gap for women living for women living in the most deprived areas. It's sort of like 65 years, and then for in the least deprived areas, it's 75 years. And it's similar for men. So essentially what you see here for women is it's not just that they live shorter lives. Obviously, there is a life expectancy gap, as we saw, but it's also that they spend more of those shortened lives with major illness. Okay, so this is sort of setting the scene for what's happening now. These are current patterns of diagnosed inequalities in illness. So what do we expect for the future? So this I don't have a graph for this, but essentially this 10-year gap is going to stay the same. So the overarching message is that health inequalities are not going anywhere. If current trends in risk factors were to continue as is, health inequalities will persist into the future. So in terms of then healthcare demand, it's also important to see, I mean, we've been looking at sort of shares and prevalence and things, but it's also important to know what does this mean in terms of the numbers of people. So that's what this is showing. This is showing you the change in the number of working age people. So again, focusing on working age here and to focus on the implications beyond health and on economic growth as well. This is showing you the the change in the number of working age people between 2019 and 2040. How many of those are people with major illness? How many of those are people without major illness? So overall, we are going to see an increase of working age people with major illness from 3 million to 3.7 million. So that's a 700,000 increase. But what we also find is that increase is not going to be uniformly distributed. 80% of that increase in working age major illness will be in the more deprived half of the country. So that's deciles 1 to 5 here. And that's essentially what we're trying to highlight with the red bits and the curly braces. So there are clear implications and potentially knock-on effects, and who is then able to participate in the labor market and productivity and local economies and all that sort of thing. Again, moving on to what does this mean for specific conditions. So this is showing you the difference in the age standardized prevalence between 2019 and 2040 for the 7 conditions that we have been talking about. And so you can see that the pattern is very different. Different conditions show different patterns of health inequalities. So if we start from the right of the chart, that is the positive side of the chart. So that's showing you a success story. So CHD and stroke, we are seeing an overall decline in the prevalence of those conditions, but also a narrowing of inequality because the decline is steeper in the most deprived areas. And this is obviously attributable to the public health policy successes of smoking because those conditions are quite causally linked to smoking. So with the smoking reductions that we have seen over the past few decades, because people in the most deprived areas are more exposed to smoking, you would expect a bigger reduction in smoking-related diseases compared to the less deprived areas. So that's essentially what we see, for instance, on the right-hand side of the chart. But now if you then focus on the extreme left side of the chart, that's the sort of polar opposite. That's exactly what we don't want to happen, is a widening of health inequality when it comes to type 2 diabetes. Because type 2 diabetes is quite strongly causally linked to obesity, and we project obesity to grow into the future. And so because of that, and because obesity is more prevalent in the more deprived areas, you then expect a bigger increase in obesity-linked diseases like type 2 diabetes. And so there is an overall increase in the prevalence of diabetes, but a bigger increase in the more deprived areas, leading to a widening of inequality. And again, these are shares. What does this mean for the numbers of people? So if you look at among the top 7, or the 7 conditions that are contributing most to health inequalities, these 3 are the conditions that are going to be the most prevalent. They are the most prevalent now in both the most and the least deprived areas. They will continue to be the most prevalent in the most and least deprived areas, but the increase in the number of people with these conditions is going to be much more in the most deprived areas. And that's essentially what this is showing. And so, yeah, that's what we find. What does this then mean for the implications of our findings? So obviously, health inequalities are not going anywhere, unfortunately. If current trends and risk factors were to continue, we are going to see them stubbornly persisting into the future. And this has implications not just for health, but for the wider economy as well. So obviously, you have huge implications at the person level, the fact that you have people having major illness in the most deprived areas in their early 60s, and huge swathes of the population having to experience this at a much earlier stage has implications for people. But also at the system level, we saw that some of the conditions that are going to see the largest growth are things that are largely managed in primary care. So things like chronic pain, diabetes, anxiety, and depression. So there is definitely a healthcare setting implication for these findings. But not just that, we saw that that growth is going to be much more in the most deprived areas. And we know that there is a sort of inverse care law in place. And so essentially we need primary care in more deprived areas has fewer GPs relative to need. And so we have to make sure that investment is then tailored accordingly. People obviously have been talking about prevention. I mean, all of these results can be directly attributed to trends in risk factors. And we saw the public health success with smoking-related diseases in that one of the previous graphs. So prevention obviously has a key role to play here when it comes to risk factors. But also the action focused on the wider determinants of health, so things like, good quality housing, secure employment, green space. We increasingly are getting evidence about the impact of this on health, so we need action on that. But again, like I said, this is not just a health issue. The current government obviously is quite focused on economic growth, and so we cannot think about these things in sort of separate bubbles or vacuums. They're all sort of intertwined. So obviously, the fact that this increase in major illness is going to be unevenly distributed, there is a risk of further exacerbating economic inequalities. They're going to happen in areas that are already more deprived. And so this can have knock-on effects on who is able to participate in the labor market, their productivity, and wider economic growth. And also employers potentially probably have a role to play as well, because we have separate Health Foundation research showing that you have now as many people in work with work-limiting health conditions as people out of work. So there is a role for employers in terms of how can they support their employees to be able to work to the best of their abilities, to however way they can with different long-term conditions. There's also implications for pension policy. So for instance, if you have, again, vast swathes of the population getting major illness in their sort of early 60s while they're still in working age, and with a sort of policy towards increasing state pension age, that then means that you are potentially out of the workforce and then waiting because of illness and then waiting your pension for longer, which can then push you into financial hardship or poverty. So lots of different angles in terms of the implications. And then, yeah, just wanted to end by saying, yeah, it's not just a health issue that has wider economic implications. And so if we need economic prosperity, we need to be tackling health inequalities. Thank you very much. Just some things, the full report that's the link there. And I've also added the GitHub links to the analysis that we have done on our panel, which is the first one on the Health Foundation analytics page. But also the microsimulation model is actually open source, and that's the final link as well on our collaborators page. So thank you very much.
Thank you, Anne. There are a staggering number of questions on Slido that have come in from online. I'm going to point people who, most of them are very specific or quite detailed questions. Okay. I'm going to point them towards you directly in terms of using your contact details. We've just got maybe 3 or 4 minutes left. I just wonder if there's a question in the room that we could ask Anne to respond to. So could you pop your hand up if you have a question, and I can run to you with the baton. There, oh, nice and near.
Yeah, thanks, Anne. So I suppose, as we know, how obesity affects the risk of incidence of all those conditions, could we start to produce different scenarios where you could look at, say, different obesity prevalences and then how that affects incidence of all those diseases and feeds through? You know, obviously, you showed how like smoking reductions have impacted on the circulatory diseases. So we could sort of model some of those population impacts, maybe.
Yeah, so that's exactly one of the reasons why that model was set up, is the fact that it is equipped to do scenario analysis. So for instance, if you knew a policy for instance, the junk food ban was instituted, and you know how that fed into obesity prevalence, you would be able to then use that to fix the risk factor at a different level to the baseline, and then look at how that feeds into multimorbidity. So that's possible. So even without any sort of policy, I mean, the only thing with using a specific policy is that it's then rooted in some kind of reality. But then you can also do completely like any kind of, if you assumed a population-wide reduction in obesity prevalence of X or Y, or even targeted improvements where the most deprived areas had a reduction of X or Y. Like, the model allows for all of that. So the scenario analysis can be done. And I think the team are very keen that, you know, we also think about how do we use this model, the application of this model, to then look at some of those things to make those cases, I guess, more strongly.
Can I get back so I can put your contact details up? There we go. So if people have got particular questions, if I could encourage them to contact Anne directly. Thank you very much. We're going to head to a break now, and then the conference